Welcome and thanks for joining us. I'm Bianca Romanic, the CEO of Storm Skills Training. In this webinar, we're focusing on women and suicide. More recently, suicide prevention efforts have focused on men, and that's understandable. However, it shouldn't mean that we don't focus on the unique needs of women and girls. I'm absolutely delighted to welcome two very special guests. The first, Emeritus Professor Linda Gask. She's the co-founder of Storm Skills Training, the reason I have a job, retired clinical psychiatrist, and more recently, an author. Her most recent book focuses on women's mental health and how we're not getting it quite right. The title, Out of Her Mind. A very warm welcome to Linda, and thank you.
I'd really like to change the focus of the way we talk about suicide and mental health from thinking about the whole population, where we know that it's twice as common in men as in women, and to really get us to think about women. This is something that I think from a policy direction hasn't happened a great deal in recent years. We've understandably been talking about men. And the problem, because we don't have that gender sensitive focus, is that we don't really pick up the nuance of how things are different for men and for women and girls and boys. We know that gender plays a significant role in how we experience mental health problems. The latest adult psychiatric morbidity survey in England and Wales showed that during their adult years, 1 in 4 women, compared to 1 in 7 men, experience a common mental health problem, anxiety and/or depression. So we know that common mental health problems are more common in women, but that covers up the fact that there's an intersectional element here, that morbidity is increased if you're poor, if you're from a minoritized ethnic group, if you're LGBTQ+, and we need to think about not just women as a whole, but women from different backgrounds and the different problems that women face in our society. Young women are an increasing cause for concern. And it's extraordinary how, when this was reported in The Guardian, when the APMS came out, there was almost no discussion about it in the media. It's young women. Young women just complain. Young women are just difficult. There's a real sense that their problems aren't taken seriously. But it's very worrying that you see these bars moving further apart. The share of young women in England reporting a mental health problem condition is now the highest on record. This is young women between the age of 16 and 24. And this is not self-reporting. This is according to the Adult Psychiatric Morbidity Survey, for which the methodology hasn't changed over the years. So the gap is widening. Women are becoming more and more distressed. And I think we have to think, why is this? What's going on in our society that's making life so difficult for women? And some things I think are pretty obvious. I think there is an epidemic of violence against women and girls. In many ways, I think it's harder to be a woman than it was when I was growing up. And these early years of womanhood are, I think, a high-risk period. Agenda Alliance is an organisation that's been campaigning for better mental health care and attention to what's going on in society for women for over a decade now. And they produced a report in 2016, which I don't think the situation has changed in any way since then. It may even have got worse. It was called Hidden Hurt, Violence, Abuse and Disadvantage in the Lives of Women. And around half of women who have mental health problems have experienced some form of abuse, physical, sexual or emotional. Women are more likely to experience sexual abuse than boys in childhood. Girls are more likely to experience sexual abuse. And over a third of women who faced extensive physical and sexual violence in childhood and adulthood have attempted suicide. So we're really talking about women who from an early time in their life are facing a great deal of trauma, and that impact is not getting the attention that it deserves. There are certain types of mental health problem that are undoubtedly gendered when you look at the epidemiology. I've mentioned depression and anxiety. Eating disorders is another one of those. And we know that during lockdown, the number of young people with eating disorders increased. It was a very difficult time to have an eating disorder, and it was extremely hard, as ever, to get access to help. There are deaths from anorexia nervosa each year, around 40 in England and Wales, and they are almost all women. And some of those deaths will be from the illness itself, some of those will be from suicide. And there has, of course, been considerable discussion around assisted dying and mental health problems. And we do know that there is a whole debate going on within eating disorders about whether starvation is a form of self-harm, which I find extremely worrying, because when you are starving, that impacts your ability to think clearly and make decisions, and you should be treating this as starvation, not starting to think, is this a form of self-harm? But this is a debate that's currently going on within the eating disorder community. The big thing about being a woman is that we have a menstrual cycle, or at least we do until we get to menopause. And I was taught almost nothing about the impact of the menstrual cycle on mental health as a psychiatrist. But there is a risk across the menstrual cycle of experiencing mental health problems. And certainly in your youth, there's a risk in the late luteal phase of having premenstrual dysphoric disorder. And that isn't simply PMT. It's much worse than that. And we know that it's associated with self-harm and with risk of suicide. And then, of course, when menstruation, in late menstruation, there's also, the late part of the menstrual cycle, there's also a risk of suicide as well. So the menstrual cycle has an impact on our mood. And as a clinician, I would see women who had exacerbations of their depression during the menstrual cycle. And this was often completely dismissed by those who were involved in their care. But it plays a part in their ability to have stability of mood. And I think it's very important. I just don't think we have spent enough time thinking about the impact of the menstrual cycle on mental health. During childbirth, we've got a major issue with mental health, perinatal period. We know that from the Embrace report that deaths from mental health related causes account for a large proportion of deaths between 6 weeks and a year after the end of pregnancy. And this has been pretty much unchanging now for several years. It's a major issue, but again, I don't think it gets sufficient attention. One of the issues, I think, is the inability of different parts of the health service to work together. And we've had major investment in women's mental health, but we still have problems for women who've experienced birth trauma, getting sufficient help for the impact of that on their mental health. And then, of course, menopause. And the peak age for suicide for women is age 50 to 54. The relationship between that and menopause, we're still trying to discover. But I think we mustn't make assumptions that the reasons why women take their life at that period of their lifespan is the same as men. We have to be trying to find out what impact gender has on suicide. And a lot of the evidence is not particularly strong, but certainly we do know from qualitative reports about women's experiences that menopause can have a significant impact on their mood stability. And we also know that new psychiatric disorders can occur during the menopause, and that if you have severe mental illness, this can be exacerbated during the menopause. And if you've had perinatal mental health problems or problems in your teenage years with PMDD, you're more likely to have mental health problems during the menopause. Suicide and domestic violence were not something that were linked together in the sort of broad view of the topic until relatively recently. We know that there were women who went to prison for homicide, changed to manslaughter in many cases, because of the violence that they were experiencing from their partners. But you may have seen reports in the news. Scotland, I think, was the first country in the UK to actually convict somebody as a result of the suicide of his partner. And I'm looking forward to hearing more about what Pauline can say about the current data on this, but this is the data from the National Police Chief Council. One of the most gendered diagnoses in psychiatry is borderline personality disorder. It's 3 times more likely to be diagnosed in women. And I have real concerns about how easily women are given that diagnosis. I think that there is a difference of opinion about this, and that many people who work from a psychoanalytic perspective will disagree with me and say borderline personality disorder is a coherent diagnosis, but others, like Peter Tyrer, who's an expert in personality disorder, sees it as being far from coherent and having a considerable overlap with mood disorder. These comments here are from a booklet by Recovery in the Bin, and they are some points of advice about how to avoid receiving a diagnosis of personality disorder. I've known professionals who are offended by this. I've known others who've actually thought, yes, it's all too easy to be given that diagnosis. Don't argue your point of view with professionals. Don't complain about anything. Know exactly who you are. Don't change your hair colour, and don't attempt suicide. Make sure you're successful, or it will be deemed attention seeking. And my concern is that these women are not getting a proper assessment. And Jay Watts, who's a clinical psychologist who's campaigned a great deal on this issue, says that if we unpick this, there are all sorts of ways in which different diagnoses underlying this. Diagnostic injustice, diagnostic overshadowing. And I would pick out their autism and ADHD because I've met many women who've been given a diagnosis of borderline personality disorder and have been found to be autistic. I've re-diagnosed women with that diagnosis with bipolar disorder and complex trauma. The vast majority of people given this diagnosis, not all of them by any means, but vast majority have experience of trauma. And it's all too easy to get this diagnosis after you've experienced early trauma or even after you've experienced domestic violence. We have been seeing in England the recriminalisation of suicidal acts. I have real concerns about the ease with which the police have been involved with people who are clearly in distress, and the SIM monitoring system was disbanded, I'm very glad to say. But I think the point of view that these people, usually women, should be criminalised for attempting to take their own life, and in fact then in some cases denied all access to mental health care, is really worrying and is putting people at risk of serious harm and of death. The other thing that I think we should be really concerned about at the moment, and it's very easy to see this when you read the newspapers, are the number of young women who are dying in mental health units or shortly after leaving mental health units. And we've had inquiry after inquiry. John Baker, who is Professor of Nursing in Leeds and who I interviewed for my book Out of Her Mind, talked about how we're now talking about trauma-informed care on wards where we actually re-traumatize patients and we wonder why they don't get any better. The last thing I want to mention is women in prison. And women don't get thought about much in prison because there are so fewer women in prison than there are men. But they are a very vulnerable population. They are 9 times more likely to die from suicide than in the general population. And there are serious shortcomings in perinatal mental health care in prison and in perinatal care in general. Women have given birth to children on their own in prison. And we really have to think, why are we shutting this group of women away when many of them are in prison because of things that men have done? Katie Allen is a young woman who died aged 21 in Polmont Young Offenders Institution, having been bullied in prison. And her mother has led a tremendous campaign to try and get action taken and to do something about what's happening to young women in prison, all women in prison. I'm going to end with a quote from Emma Price Jones, who writes on Substack, but is also someone who is a lived experience person in Australian mental health care. And this quote really drew my attention. It was earlier this year when I saw it. And she was talking about how the direction is all about men's mental health care in Australia, getting men to talk. It's very, very important to get men to talk. And it's the same in this country. She said, women's distress is often endured silently, with those who do seek help often labelled as attention seeking, based on a foundation of medical misogyny and the legacy of hysteria. The phrase "don't suffer in silence" is central to messaging around men's suicide. But for many women, that's precisely what defines womanhood: suffering in silence. The Royal College of Psychiatrists' Women's Mental Health Strategy is going to be launched very shortly. And that is one way that we're hoping to bring more attention to issues surrounding women in mental health care. Thank you very much.
Thank you, Linda, and we look forward to keeping our community up to date with the publication of the Women's Mental Health Strategy. Our next very special guest is Dr. Pauline Turnbull. I first met Pauline at a suicide prevention conference a number of years ago, and she was presenting on the very topic of suicide and women. I was struck by her passion, clarity, and academic prowess. Now the project director and academic lead of the National Confidential Inquiry into Suicide and Safety in Mental Health, also known as NCISH. This is a globally important project that we all turn to make services safer. Today, Pauline focuses on findings from the NCISH dataset about women who have taken their own lives. A very warm welcome to you, Pauline. Thank you.
Thanks very much, Bianca. So a lot of what I'm going to talk about here when I'm listening, when I'm thinking about the data that we're presenting in relation to suicide by women, is going to reflect some of the things that you've heard Linda mention already. So this slide in particular looks quite familiar. What we're looking at here is the suicide rate in the general population. This is based on date of death occurrence. And the first thing that we see, as we know, is that 2/3 of the people who die by suicide are men. And when we're looking across the whole life course and all of the different groups, the highest suicide rate that we see is in men in midlife. Now, quite rightly, what that has led to is a particular focus on suicide prevention for men in recent years. So we've seen some fantastic innovative interventions looking to support men in crisis. We've done our own work on this as well. You can see a report there, which is by the unit that I work for, which is suicide by men in midlife, that group that I just mentioned. But what this means when we look overall at the evidence that we have for suicide prevention is that for the most part, those studies group everybody together. And sadly, what that means for women, this lower line here, these are women who die by suicide. They are in such crisis that they take their own lives. Everything that we know about suicide prevention is driven by the characteristics, the life experiences, and the clinical need of men, purely because in statistical terms, when we're grouping everybody together, that is the largest proportion of the group that we're seeing. So unfortunately, what happens is that women and suicide prevention for women becomes relatively invisible in the evidence that we have. There is some evidence about suicide prevention for women, and I'm going to be talking about that today, specifically evidence that comes from my unit, the National Confidential Inquiry into Suicide and Safety in Mental Health. Now, where we work, we do look at suicide prevention for all groups, and that includes the general population, but one of the major things that we do is to look for factors in mental health care where clinicians can make change to their practice to improve safety for all of the patients that they care for and to save lives. So that's suicide prevention specifically in mental health care, and that's a lot of what I'll be talking about today. So our methodology when we're thinking about suicide prevention for people who've been in recent contact with mental health services, the starting point is that same information that you've seen Linda talk about, you've seen me talk about. It's that national mortality data. So we're starting from the same place that we see these official statistics. Stage 2 is identifying of those people who died in the general population by suicide, who was it who was in contact with mental health services in the 12 months before they died? So that's a year before they died by suicide. And then our final stage is a detailed data collection by a questionnaire. That's historically been completed by consultant psychiatrists, but more recently it's completed by whoever is on the clinical team who had the most contact with the patient before they died. And the first thing that we can look at when we're thinking about this methodology is who is in contact with mental health services. And there's already a difference when we're looking at between men and women. So we know that of men who die by suicide, 22% of them were in contact with mental health services in the year before they died. And for women, it's a higher proportion. And that is likely to reflect a large proportion of women who've been under recent mental health care. But the other thing that we've got here is actually the fact that 35% of women who die by suicide have been in contact with mental health services. It gives us a greater opportunity for intervention. These are people who have contact with services. These are places where we can find modifiable factors, where we can change practice to support these women. Okay, so looking at the age distribution of patients in general, this might be a distribution that many of you are familiar with. It's certainly one that we've used when we're talking about suicide prevention for men. And what you can see here is that overall, the distribution of patients who die by suicide is similar for men and women. We know, as I've already mentioned, that the group with the highest rates of suicide are men in midlife. It's slightly less talked about that is also the group where the highest rates of suicide are for women. So women in midlife have the highest rates of suicide for women, both in the general population and among patients. I want to talk a little bit about the work that we've done at looking at different groups of women. So over the next few slides, I'll talk about suicide prevention for different age groups, but also a few different clinical groups. So firstly, thinking about young patients. So this is female patients aged under 25. Now there has been, both in the general population and the patient population in recent years, an increase in suicide rates by young women, although there is a signal that this increase may be slowing or leveling out. There is a chance that this increase in suicide rates in young women has been affected slightly by some changes in the way that we count suicides in England and Wales. But in addition to that, it's also likely to reflect some actual increase in suicide in this group. And it's certainly a group where we need to place some of our focus for suicide prevention. And just thinking about some of the key findings that come out when we look at young women who've been under the care of mental health services and died by suicide. The vast majority of these women had a history of self-harm. And actually, around 2/3 of them had recent self-harm, so that's known self-harm in the 3 months before they died by suicide. And one of the reasons that I'm mentioning this is to put this in the context of what we know about self-harm rates for young women. It's quite well known that young women have high rates of self-harm. Now, this is a concern for suicide prevention in the sense that self-harm, sadly, in some instances can feel a little normalized, a little dismissed in terms of the risk of self-harm because of those high rates of self-harm among young women in general. But self-harm is very much associated with suicide, and appropriate care, treatment and management of self-harm is suicide prevention. Now, there have been concerns, as Linda mentioned, in recent years about inpatient safety in general and for young people. And when we looked at inpatient suicide by young people, we found that around 2/3 of young people who died on inpatient wards were women. So this is no longer following that ratio that we see of more men than women dying by suicide when we're thinking about inpatient safety. So inpatient safety may be a particular concern for young women, and of those young women who died by suicide whilst being an inpatient, many of them died on the ward. So that means that they weren't on leave at the time of their suicide. and also many of them had been detained under the Mental Health Act. So when we're thinking about improving ward safety, we definitely need to think about young women and their experiences of inpatient wards. Now, going back to this graphic where we looked at the age distribution of patients and coming back to the highest rates of suicide among women being in women in midlife, the thing to mention here, and Linda alluded to this, is that there is a lack, unfortunately, of national data about suicide prevention in this group. We are looking at this currently, so we are planning to publish what we know from our national data set about suicide prevention for this group. The other thing to say is that this is an area of emerging evidence, and actually a lot of that evidence is coming from lived experience or smaller studies where people are able to talk to women about their experiences around midlife. As Linda mentioned, it's very likely that there will be some hormonal influences, but this won't be experienced alone. We also need to think about the social factors and socialization for women, as well as the life problems that they might be experiencing at this time in their life in relation to suicide prevention. So thinking about a few clinical groups, and actually these are some clinical groups that you've already heard a little bit about what's happening for mental health care for women. Now, going first to patients who've been given a diagnosis of personality disorder. This isn't particularly a diagnosis that we favour in our unit, but when we're looking at patients who've been given a diagnosis of personality disorder, who've then died by suicide, there are a few things that stand out, a few key findings that I want to highlight here. As would be expected for a diagnosis that is highly related to a history of trauma, there was a high proportion of women who died by suicide having been given a diagnosis of personality disorder who had experience of childhood abuse and domestic violence. There's also a high proportion of these women with a diagnosis of personality disorder who had a history of self-harm. And again, this is something that is intrinsically linked with that diagnosis. One of the things that I want to mention here is that 45%, so almost half of the women who took their own lives and had a diagnosis of personality disorder had been seen in the emergency department for self-harm in the 3 months before they died. So that is really recent experience of self-harm, and it's extreme enough, if you like, for them to have visited the emergency department. That is, again, a huge opportunity for intervention and a huge opportunity for self-harm care to be given according to the guidelines that we have. Again, thinking about opportunity for intervention, these aren't people who are out of contact with services. These women who've been given a diagnosis of personality disorder, over half of them had contact with mental health services in the week before they died. When we looked at the services that they had contact with more generally, the other thing that I want to mention here is that a relatively small proportion, so only 11% of these women, had been seen in specialist services for personality disorder. We did look in a different study that we undertook about personality disorder and suicide prevention. We did ask people who had personality disorder, their carers and clinicians who worked with people with personality disorder, about what works in services. And one of the things that came out really strongly was that these specialist services for personality disorder are excellent, and many people are not able to access them. We also looked at suicide specifically in this relatively recent paper among people who'd been given a diagnosis of eating disorder. Now, this paper and the data that I'm presenting here, it does combine women and men, but as you might expect, the majority of these patients were female. This was the largest study into suicide by people with eating disorders that we could find in the evidence and in the literature base. And there's a couple of things that I want to mention here just to bring out of this more detailed study. One is that comorbid diagnoses, so more than one psychiatric diagnosis, was very common in this group, and the secondary diagnosis was most often depression. And when we looked at the people who died, so the people who took their own life having a diagnosis of eating disorder, we found that they had a longer duration of illness. This is consistent with some other evidence about suicide attempts in those with eating disorders, where it's people with a longer duration of illness, so people who've been suffering for a longer period of time, that have more suicide attempts. So this is reflected, sadly, in this group. I want to spend a little bit of time talking about domestic violence and suicide, and I'm going to provide a little bit of context initially, although this isn't the first that you've heard about this being a particular priority for suicide prevention. So in 2023, in the suicide prevention strategy for England, domestic violence was mentioned specifically for the first time. And one of the things that is in this strategy is kind of emphasising this need for a greater evidence base and to inform suicide prevention for people who've experienced domestic violence. Recently as well, echoing something that Linda has already talked about in her talk, we know that in recent years, in domestic homicide reviews that have now been renamed to domestic abuse-related death reviews, the number of people who die by suicide in recent years has outnumbered the number of people dying by domestic homicide. And the other thing that I want to mention, alongside the upcoming women's mental health strategy from the Royal College for Psychiatrists, is the renewed women's health strategy for England. So there is an increased focus on domestic violence, specifically when we're thinking about suicide prevention. But as with some of the other areas, this is emerging evidence, and certainly there is room for more evidence. I'm going to talk about what we've done from our data, looking at domestic violence in relation to people who've been, so women who've been under the recent care of mental health services. I've started this slide by putting up the question that we have historically used in our questionnaire for our data collection on domestic or intimate partner violence. Now, we have revised this, but I am sure that any of you working in the field will be aware of the limitations immediately when you look at this question. As this was phrased, which is the phrasing that will reflect the data that I'm about to talk to you about, this question does not explicitly include reference to psychological violence or coercive control or financial control. This is a limited question, and we do think there are issues with it. We've since expanded what we're asking clinicians, but this question is what the data is based on that I'm going to talk to you about. One of the reasons this is so important is to reiterate that I am only presenting information about women where the clinician knew there was experience of domestic violence and based on this limited question. So everything that I talk about is likely to be an underestimate. Even so, we found that 1 in 4, so 26% actually, female mental health patients who died by suicide had an experience of domestic violence. We published this study after the Royal College of Psychiatrists spoke to their clinicians about the experiences of the female patients under their care. And one of the things that came out from this survey of clinicians, this survey of psychiatrists, was that over half, so I think it was 55% of clinicians, said that their female patients had experience of violence or abuse. And when we looked at what these women were experiencing, we found that over the whole group, so women who'd experienced domestic violence or had known experience of domestic violence, and women who had no known experience of domestic violence, the whole group had recent adverse events. And this is consistent with what we know about a lot of suicide prevention, where suicide, you will have often heard people talking about suicide being complex. Suicide is not one thing. Often it can be underlying and historical factors exacerbated by a recent adverse event. But when we specifically looked at women who had an experience of domestic violence, we found that some of those recent life problems or adverse events set them apart from other women who died by suicide. So for women with experience of domestic violence, they most often had serious financial issues, job benefit or housing loss, and family issues. And they also more often lived alone, they were unmarried and unemployed. And I want to emphasize that these factors are known to be associated with suicide. They are also known from the literature to be associated with domestic violence. So what we're seeing here is intersecting disadvantages for these women who sadly take their own lives after having experienced domestic violence. And when those women had experience of being inpatients before they died by suicide, we also found that they were more often discharged to other problems, so discharged back to known problems with alcohol or drug misuse and poor social support. As you might expect, we found more diagnoses of personality disorder, which, as I've already mentioned, is a diagnosis that is associated with experience of trauma, and more diagnoses of PTSD. The majority of these women who had experienced domestic violence had a comorbid mental health diagnosis, so that's more than one psychiatric diagnosis. And when we looked across a few of these factors combined, we found that around half of these women had a combination of self-harm, comorbid diagnosis, and alcohol and or drug misuse. So this is indicating clinical complexity that services might find difficult to respond to. So we've talked about suicide prevention for a few different specific groups, a few different ways that we might look at the data when we're thinking about how we can help to prevent suicide and improve safety for women. I'm going to draw these together now in some key messages to take away. And specifically, these key messages are for clinical services. What we're looking to do is to make recommendations where people can actually make measurable changes to practice to improve safety for everybody they care for. In this instance, it's for the female patients under their care. We need self-harm care provision to meet quality standards. I said this earlier, it bears repeating that appropriate self-harm care, treatment and management is suicide prevention. Most importantly, we need safe and compassionate care for patients who've been given a diagnosis of personality disorder. And suicide prevention needs to become and remain a priority for many services, but specifically from this literature, from eating disorder services and domestic violence services, as well as under mental health care. When we think about the experiences of the women that we know have died by suicide, we need to ensure that assessments, formulations and safety plans need to ask about and address early life experiences as well as current adversities. And I talked about clinical complexity for those women who'd experienced domestic violence. Actually, a certain level of complexity is seen in all the women who died by suicide, having been under recent care of mental health services. One of the concerns that we have about this complexity is that some of these factors that I mentioned specifically in relation to domestic violence, so factors like a history or frequent self-harm and alcohol and drug misuse, unfortunately, these can be used as a mean to exclude people from specific services. We need to be ensuring that women in crisis are not excluded from services that could help them as a response to their clinical complexity. People also need to consider the context of social disadvantage. And for many of these women, again, thinking about that social disadvantage, those intersecting disadvantages, a public health approach would actually be most effective. So yes, we do need to think about what does this mean for clinical services, but we also need to think about supporting people economically with employment and with housing support. my final plea is to say that most importantly, we need to continue to disaggregate statistics and suicide prevention analysis by sex. We need to ensure that women in crisis don't remain invisible, and that we're clearly looking at the data that we have so that we can really tailor and focus our suicide prevention efforts to support these women. And that's the wonderful team who've helped with all of this data collection and analysis. Thank you.
Thank you, Pauline. And absolutely, we need to learn from the deaths of these women and make sure that women in crisis are no longer invisible, and that we improve our services to provide specific care around the specific needs of women and girls. We now change gears a little bit in our webinar, and we've got the opportunity to have a sneak peek into a lovely conversation between Linda and Pauline about women and suicide. So I'll hand over to the two of you now and enjoy. Thank you.
Pauline, I thought your presentation there was absolutely brilliant. And I'd just like to ask, have you at the National Confidential Inquiry put all that information from the studies that you've already published? Is it possible to find all that in one place as yet?
I think it's a great question, and the answer is that it will be. This is another element that really reflects, I think, the increasing focus in the last few years on women and suicide prevention, which, it is a positive. We've both talked about how there hasn't been enough focus in this area. It's an area of emerging evidence from other places as well as from us. We haven't aggregated it all together before. We haven't pulled all of that into a clear narrative before. And I think that that's one of the next steps that we need to do. Maybe taking inspiration from your excellent book.
Thank you very much for that. Now, I think it is interesting that we've had a change in focus. Have you noticed any difficulty with those interested in men's mental health actually saying, yeah, why are you not focusing on men? Because they're the big problem.
I'm already thinking that I would love to ask this question back to you as one of the front runners in getting this information out there. Sadly, what we do at the unit where I work, we have this huge national data set, and then sometimes we're collecting other data sets as well, quite often on a national basis. So we're able to look at, it's longitudinal as well. So we've been collecting data since 1996. We're able to look at changes over time. We're able to look at different groups. One of the things we aim to do is to respond to different priorities as they emerge. And one of the ways that we can do that is by looking at, well, where is the group with the biggest numbers? If we're looking at the group with the biggest numbers, we can make the biggest change. On a personal level, I found it very difficult that whenever we talk about women, we have a little bit of backlash from people who are campaigning for suicide prevention for men. I said it in my presentation, I'll say it again. I think it's quite right that people are campaigning for suicide prevention for men. We've done a lot of work in that area. It's a little bit whataboutery, really. The fact that we haven't been focusing on women means that at worst case, I think that being female can be seen as a protective factor against suicide, and that is simply not true. What that means is that for these many women who take their own lives by suicide, we are just not learning enough about how to support them. And I really want to give, almost the same question back to you, but I know that you've been working in this area for quite a while. So I'm also curious as to what was the process that led you to publishing your book, Out of Her Mind, when you did? And was that a struggle to get there? Was it a struggle to get that information out there?
I worked in a community setting for many years. So I was working with a primary care mental health team, providing psychological therapies to 2/3 of them. Our patients were women, and almost all of the staff were women. And so I was working in Salford, And it's very difficult when you work in that environment not to become increasingly aware of the issues that women face on a daily basis and the association between all of those social factors you talked about and self-harm and suicide. And we were seeing women who there was no service that would be able to help them with their trauma. The 6 sessions of CBT is not going to help somebody who's been through domestic violence, and it's not going to help somebody who's been abused in childhood. And we've increasingly lost the third sector organisations that used to be able to help and support women. Salford has now lost its women's centre. And so it was that was a big influence on me in thinking about this. I mean, I started to work with women as a psychiatrist in training in the 1980s when women's mental health concerns were kind of on the up because of feminism. And then I became an academic and I kind of focused on a particular area of primary care mental health. But my clinical work, because I worked with people with depression, was very often with women. And so you kind of reach a point where you start to look back and think, I've just spent several years working in an area where women are not getting what they need. And these are not inpatients, these are women in the community. And their problems are very often written off as being minor, when some of them are in and out of contact with mental health services, exactly like you described. They have complex problems. And so that's how I came to write about it. And I also really wanted to hear women's stories. And I think when you're talking about complexity is something we've moved away from, really being able to handle complexity in mental health care. We just don't. What I learned from those women is that no one sits down and listens to their story with them. It's all about diagnosis, which is fair enough, but it's all about diagnosis equals treatment equals a brief period of management. And the women that I cared for who had complex problems when I was younger, as a consultant psychiatrist, had continuity of care. And we got to know them over time. And you simply can't manage women with complexity without getting to know them and knowing their stories. And so I think that leads me back to asking you about what we need to do about inpatient care for women, because something's going badly wrong in inpatient units. And I know there are issues around safety and about security and all of those things, but relationships must come into that as well. And whether we're paying enough attention to the ward culture and training and all of those things.
That's exactly right. And what's really heartening is to hear that lived experience of working with women on inpatient wards and thinking about your experience as a clinician and how you're looking at inpatient wards and how much that is reflecting what we're seeing and what we're concluding from the data that we have. So when we think about inpatient safety in general, what we've seen over the years is a decrease in suicides on inpatient wards. And
yes,
and this is over a long time, really. So
yes,
initially, the focus on safety for inpatient wards was quite physical and quite practical. We were thinking about the physical changes that can be made to wards to prevent suicide. And a huge impact of that was a reduction in numbers and rates of people dying on inpatient wards. And what we've seen more recently, when we're thinking about the data as a whole, is that is levelling off. So we're not continuing to see improvements in inpatient safety. And I think that needs exactly the change in focus that you're talking about, which is when we're thinking about inpatient safety, it's actually about creating an environment where people want to stay on the ward. So one of the things that we find is a lot of people who die by suicide as inpatients, although less so in those young women that I talked about, they've absconded from the ward or they're on leave. So they are taking their own lives when they're not in that environment. So one of the things we need to do, both from the perspective of people who are leaving the wards and of those women who are detained and die by suicide on the wards, is to ensure that it feels like a therapeutic environment, that they're having these relationships with the people who are working with them. And that's, it also reflects that kind of personalized approach to working with people, which we've talked about in terms of a personalized approach to risk, but actually it's just a personalized approach to understanding people's experiences, both what they've been through previously, what they might be discharged to as well. And it's the other thing that I was thinking when you were talking is how much some of our focus on suicide by women has been driven by people working in these services who come to us and say, look, you need to focus more on this group. This is what we're seeing. We tend to hear the stories before we see it in the data.
That's really interesting. I think it must be very hard to work on some of these units and not want to make changes, but very often not being in a position of power to be able to do that. You asked me about getting hold of data, and I found one of the really frustrating things in trying to understand women's mental health care was the lack of disaggregation of data. In official reports, government reports, the data are there, but you can't actually dig things out. And I'm so pleased that there's now an increasing focus on that. The Message project that Kate Womersley is involved in leading. It's really making a difference. People are beginning to talk about that. How much is going on in terms of thinking about a more gender-informed approach to suicide in other parts of the world? Are you familiar with what's happening in other places?
Well, that's a really interesting question. We see some different patterns of suicide globally, so we're not always seeing the same ratio. It's quite a Western ratio of more men dying by suicide than women. So when we look at places where that might not be happening, where women have higher proportions dying by suicide, what we find is that probably the suicide prevention focus, it hasn't been there quite as much as it has in the UK. So there's definitely moves forward. There's projects. There's a project that I'm involved in India about suicide prevention, and that's partly about just setting up the data to try and emulate a little bit what we have here. And that absolutely has to be a gender-informed focus there, because of so many women taking their own lives and different problems to what we experience here. I wonder if it would be possible to wrap this up a little bit, Linda, and say that in all of your experience in looking at the needs of women under mental health care, where do you think our focus should be next? Is there a particular group that we should be prioritising gathering that evidence for?
Oh, that's a difficult question, but I do think we need to think more about older women. I think older women do get forgotten about. We know that the suicide rate is lower in older people, but I think there are some older women who, in my clinical experience, were very vulnerable and isolated, and as you said, experienced particular losses and traumas. And also, when I was interviewing people for my book, what interested me was finding out that a large number of the women who end up in hospital in old age have experienced early trauma, and that may have impacted their entire lives, and is impacting them again in old age. So maybe it's just because I'm getting older, but I'd like us to think a bit about older women as well and find out more about them.
I agree.
Thank you. It's been lovely talking to you.
You too. Thanks, Linda.
Thank you.
Thank you both. What a gorgeous inspiring and really informative conversation. Thank you both so much for sharing your knowledge and experience and expertise with us. It really is appreciated. If you want to learn more about older people and suicide and self-harm, we do have another webinar recording that focuses on that particular topic. So please have a look at our website for that. That's it for today. We've focused on suicide and women. We've covered a lot of interesting ground today. And I just want to thank both Linda and Pauline for sharing their knowledge. Also want to thank all of you for watching to the very end. Hopefully it's been helpful in changing things for women in crisis. Thank you all so much and goodbye.